Welcome to Salon Talks. I'm Mary Elizabeth Williams. As many of us know, yesterday Donald Trump said he was preparing to declare an official state of emergency over our nation's worsening epidemic of opioid overdoses. The New York Times estimates that this year 60,000 people will die of opioid overdose. Today I'm joined by Dr. Indra Cidambi. She is an addiction medicine expert and founder and medical director of a Center for Network Therapy in New Jersey. But before we get started, we have so much to talk about. Let's hear Donald Trump speaking yesterday from his golf club in New Jersey.
The opioid crisis is an emergency, and I'm saying officially right now it is an emergency. It's a national emergency. We're going to spend a lot of time, a lot of effort, and a lot of money on the opioid crisis.
But you need emergency powers for drugs.
We're going to draw it up, and we're going to make it a national emergency. It is a serious problem, the likes of which we have never had.
All right, Doctor. This seems to be a watershed moment in our nation's history. It certainly seems to be a watershed statement coming out of the White House. But it's also something that has been your livelihood for your entire career. You know this crisis inside out. Tell us a little bit about how we got here. First, I want to understand that. I want to understand how we got to this place of crisis.
This crisis started very early in 2000, like in the beginning of the century. What we did was ask the doctors to ask for pain. Every patient who walks into the doctor's office were asked to identify, are they in pain? If they are, then they were prescribed pain medication. So the doctors started writing prescriptions, and that led to this crisis eventually. This was the fifth vital signs. So that is the root cause for this crisis today. Too many prescription pills for pain was written by physicians across the board, and that led to people abusing these medications. And when they ran out of the pills, they went to the street drugs like heroin, which was cheaper and it was available. And here we go.
And one of the things you've talked about that I want to mention is we've moved from a place where these opioids were in the hands of doctors who like oncologists, people who were dealing with very extreme but also possibly acute pain, into the hands of family practitioners and nurse practitioners, and that set us up to fall in terms of abuse.
Correct. More than 50% of these prescriptions were written by family practitioners and the nurse practitioners. It was not written by pain management doctors. And so restricting pain management doctors to prescribe pain medications to only 6 days or 7 days or 5 days is not a cure-all. The problem there is the first visit they might give them 7 days supply in New Jersey, but then the pain is not taken care of. Something needs to be done along with that. So, yes, they're trying to do something about this opioid epidemic, but it's not in the right direction. That's the sad thing that I have to share.
Right, and I wanna ask you about that because you have so much to say on the subject of what when we talk about earlier this week, Health and Human Services, Tom Price says we're going to be doing everything we can to support moving forward on this. But what does that word mean? What does support look like when we talk about the White House saying they're going to spend all this money? Money does not necessarily translate into solid action plan. What do you hear the White House saying is their plan, and what is an actual workable plan?
So let me say this, spending, this means national epidemic. What does that mean? National emergency means they're looking at opioid as a problem today, and they want to fix this. And that means they're going to spend a ton load of resources to fix this problem. Fine, that means money will be spent on the failing model, which is the traditional inpatient detoxification and rehabs. It's a fancy rehab centers across the country. People go there for spending the time there like as if they're going on a vacation. It's a fancy one. You don't hear that for any other chronic illnesses. So the money will be spent again and again on a failing model, which is the traditional inpatient model. Instead, if they can embrace newer modalities like ambulatory detox, which I introduced in the state of New Jersey, and I've been the medical director for Center for Network Therapy for the past 4 years. We have been running the center in Middlesex, New Jersey, and our outcomes are much better than any other inpatient that we have in the state of New Jersey. I can tell you the reason why it works is because number one, the patients are not resistant to come for treatment because it's an outpatient and they go back home at the end of the day. Number two, it integrates the home environment where they are using. Number three, it is also low cost, and it cuts costs to half of what you spend for a day in an inpatient setting. Given that, the success rate has been 65% to 70% of my patients who went through treatment at our centers continue to remain sober. That is a big success, and these kind of ambulatory detoxes should be embraced, and we should have more of these. That'll be number one. That's spending money. Spending money, where do you spend money? Meaningfully. Number two, I would say prevention is the key. There, the president was right on the money. He said, don't start. Only if you start, you need to stop. I agree with that, but that's for the future. We are in a crisis today. People have already started and they are using. How are we going to stop that? We need to do something in the interim. What are we going to do? What are the preventive measures? The preventive measures that I would think is to restrict these prescription pain pills to the ultra specialists like oncologists who are dealing with pain issues, surgeons and orthopedists, and pain management people. Not every doctor in the country will be able to write prescription, not the family practitioners, absolutely not the APNs. So then that's not it. Addiction is for everything. It's not just using pain pills. So they also use benzodiazepines, anti-anxiety medications. Again, giving the rights for addiction specialists or the psychiatrist to be able to prescribe these controlled substances like the benzodiazepines. So that will make some control. That'll be a preventive method. So it'll be like today what to do so that you don't create more addicts at this point in time. The third thing I would say is our President Trump, he said we need to prosecute these people who are using. That's in the wrong direction. There I disagree with our president. With all respect and dues to him, I cannot agree with him because who is getting affected? I would say decriminalize. That'll help in two ways. Number one, when you prosecute people who are using drugs, that means these are the people who are addicted. It's not, 4 out of 5 people who have been prosecuted are prosecuted for possession of heroin or the drugs. They are not prosecuted for manufacturing and or for sales. So these people who use are now prosecuted, and after they get treated, they are not able to get back into workforce. It really keeps them down. So that is not good. And also, if you look at it, we estimated close to $1 trillion each year has been spent on the opioid epidemic, out of which half that money is being used up by the criminal justice system. If we can decriminalize this, then that money can be used for meaningful treatment and for preventive methods. So I think those are the 3 main aspects.
I have a lot I want to talk about what you just said, but for those just joining us, we are talking today with Dr. Indra Cidambi. Sorry, I know my glasses on. And we are talking about this national opioid epidemic. This has been a political touchstone for a long time now. Let's take a look at what Donald Trump said back in October when he was speaking in New Hampshire about this crisis.
And can guarantee you, we will not only stop the drugs from pouring in, but we will help all of those people so seriously addicted. We'll get them assistance. We'll make sure that they have the top treatment and get better. We got to get them better. Got a lot of people that are strung out on bad stuff.
Dr. Cidambi, when you see that, I think many of us who have seen up close what addiction looks like and what opioid addiction looks like, I think we have concerns that the White House doesn't necessarily understand the nature of this particular type of addiction, that it often doesn't come out of recreational use, that comparing it, as Tom Price did recently, to LSD, or comparing it, for many of us who remember the crack epidemic of the 80s, or meth, this is not something that people necessarily turn to recreationally. It's something that people initially turn to because they're in real pain.
Right. Majority of people have started using these opiates for pain issues. And then the nature of the medication is such that you develop tolerance to this medication and more need to get the same effect. So that leads to wanting more pills. When the doctors cannot provide them with this medication, they go to the streets to get the fix. First, they start buying those pills, which are like, each pill costs $30. So who can keep up that habit? So they run to $5 heroin bags. And so before you see, they are into illegal use of drugs. And that has turned into this online buying of drugs. So again, our President Trump talked about putting sensors for fentanyl so that we can track fentanyl coming into the country. Protecting the border is not the focus, because today people are buying raw materials on the web, and they are also buying parts of the machine to make their own pill and put them together and make fentanyl at home. So we need to look at tracking methods to track these raw materials coming into the country through the web. So that's most important, instead of talking about putting the sensors in the airports or in the borders,
And again, you're really talking about focusing, one of the prongs of attack has to be looking at the manufacturing of it, rather than being punitive towards the people who are really the victims of this crisis. A person who is an addict, telling them that they're going to go to jail or they're going to be punished is not an incentive to stop being an addict, because that's not the way addiction works.
And you nailed it. I tell you what, 19 years, between the ages of 19 to 22, most of my addicted patients are already experiencing being in jail for a few days and or being on probation. And that's not a great model to start their life.
I have a question from Paula from Facebook. She wants to know, what should the plan be for patients who have been taking meds for chronic pain, especially those who resort to illegal means to try and to cope with their pain?
Paula has a beautiful question that she raised, because that is a real issue. That means somebody who's suffering from chronic pain, they are getting this prescription from the pain doctor who is treating them. If that is the case, the doctor can also integrate non-narcotic pain medications and other techniques to take the edge off and try to address the source of pain. It shouldn't be just taking pain pills, because pain pills are not the cure. It's not going to fix the problem. It only puts a Band-Aid on the problem, on the wound.
Right, and pain management is a growing specialization in medicine, and it's being taken more seriously. But again, we're not there yet. When we were talking earlier, one thing that you said that I really related to was, you said that we're looking at addiction treatment as being this kind of spa-like experience, rather than, and I can say this as someone who has had serious cancer, the way that we would treat a disease like cancer. Correct. Where you go and it's part of your treatment, and it's not separate from your life. It is integrated into it. That seems very hard for people to reconcile.
Right. Everybody wants to. Even the family members question when I started my ambulatory detox. They were like, "How could this be okay? They're going back to the same house where they were using." On the contrary, that's where the problem started. They need to know how not to use in their home environment. If I put them in an inpatient setting, which is a bubble, got to burst. Which will happen. So they need to learn how not to use and how to cope.
So I think many of us who are living in this world and have either had up close experience with opioids addiction in their lives, or know, or will at some point, are asking ourselves, what can we do? Because there is this sense that yes, this is a burgeoning crisis. We don't necessarily have full confidence that the White House is going to be taking care of this. So what can we as concerned citizens, friends, parents, loved ones do? What are actions we can take in our communities?
Preventive measures by being realistic, meaning teaching the family members. Even now, like every day I get new patients walk into my office and the parents are absolutely clueless what to do when they find out that their loved one or their kid is using drugs. Isn't that a shame? It should be, really explained to people, common man, what this means. When you find your loved ones using, where should you turn to? They don't have a clue, so that needs to be the first step. Secondly, we should also reduce the stigma. If somebody were to come in and say, I'm an addict, they've been treated poorly right from the pharmacy where they walk in to get their medication, and to the doctors that they go to, or the family members.
Again, in a way that you would never do with a disease.
Correct.
Like cancer or Parkinson's or Alzheimer's.
But psychiatric illnesses, in the past, we did have the stigma towards somebody being diagnosed with schizophrenia, bipolar, depression.
And still do.
Not that much. So we need to take the stigma out of the equation. That's something we need to do. And it's also, the HIPAA is another problem in there. By keeping HIPAA, the treaters are unable to talk to each other. It puts them a big barrier. So a primary care physician wouldn't know that the patient is getting treated by an addiction psychiatrist. And so if you lift the HIPAA for the treaters to communicate with each other, that helps. And at least one family member to be involved in their treatment, because addiction stands on 4 prongs. One is instant gratification, lying, manipulation, and negotiation. So people keep doing this. Lying is part of this illness. And so if we are just going to listen to the patient and treat them, we're not going too far with this. We need to have one family member at least involved in the treatment.
Now you do a particular, and you say a kind of different model at your clinic. I want to know, are there ways that the models that work are actually being integrated across the country? Is there any kind of standardization? Is there a way for people communicating with each other to say, this is what works? We should all be sharing this kind of information in terms of treatments.
That is the sad part. That's not being done. Here I am, a single doctor, an MD with an addiction specialization. As a single woman, I'm able to do so much community work. For the past 4 years, the center has been open 7 days a week, and I am there to take care of the patient. As long as it takes to get them clean and monitor them, even after they finish treatment with us, to see whether they are in the right track. If I can do this much work, can you imagine the whole nation, how much we can contribute for this epidemic? The problem is, when I started the center, everybody was looking at me and saying, you're going to kill more people there. And surprise, surprise, I detox patients from every substance that we have known to mankind. Alcohol, benzodiazepines, opiates, doesn't matter. 50% of the patients don't need inpatient treatment. They can be taken care of in this outpatient model. Are we jumping on this model? Do we have more centers? I don't see that. And there is no recognition of what I do so far. It's, many patients, when they come in, they tell me, oh, had I known this, I would have opted for this. But they don't even know such a thing exists.
Right. I mean, that's I think the big question is when we find things that actually work, how do we then share that information, and how do we collaborate in a way that medicine has traditionally done for decades and decades and decades in this country, where when there's a breakthrough, the information is shared so that then it can help the maximum number of people. And that's another thing that doesn't really seem to be...
That means we need to look at the secondary gain from this kind of treatment. If you're just looking at addiction as a treatment, then most of these fancy centers won't exist. So there is a lot of resistance because this ambulatory detox model cuts cost, higher efficacy, How many people want to do this?
Dr. Cidambi, there are so many issues around this, and I really appreciate that you have broken down the moral questions around this, because it does seem that so often addiction is spoken of as a moral thing to be cured through will or being a better person, as opposed to a disease that can actually respond to pragmatic treatment.
Correct.
So do you feel hopeful about the direction we're going in? Do you think this is a sign that maybe we can turn things in a little bit better direction if this is coming from the top down? Or do we need to be doing the boots on the ground work?
I think we need to do the boost on the ground level, because the direction that the opioid task force is putting together for the nation might come back to bite us. In 2 years, we'll be doing corrective work. I don't see that as a good direction that we are taking. Yes, those three things, as I said, decriminalizing is the best thing. It'll help in two ways, but then, the president wants to penalize these people who are using more, so that's not going to be helpful.
I have one more question from Facebook. This is from Bridget. This is a great question. Why doesn't our country have a national pain policy? What would that look like?
That'll look brilliant. We are not working on things to solve. We are only talking in the space, looking at this problem, not really understanding what is addiction, what is chronic pain. The treaters who are really working with patients are not involved in any of these policy procedures. I think the real plan needs to be put together.
Doctor, thank you so much. We've been talking with Dr. Indra Cidambi about opioid addiction. It is a huge topic. We could talk again and again. Please come back. I would love to ask you 100 more questions about this issue. And unfortunately, you're not going to be put out of business anytime soon. So we have a lot to keep talking about. Thank you so much.
Thank you. Thank you. Thank you for the offer.